the first report of a phase 2 prospective study of combination of hyper-CVAD with ponatinib in a frontline therapy of patients with a Philadelphia chromosome-positive acute lymphoblastic leukemia. I'm the lead author of this study. So today I'll be discussing the result of this phase 2 study as originally published in Lancet Oncology in 2015 with an update but recently accepted for publication in Lancet Hematology with more than 75 patients enrolled. In summary, hyper-CVAD ponatinib induced a high rate of what they call complete molecular remission, approaching 80% and higher in patients with Ph-positive ALL, with a survival. At the beginning, we reported a survival of 80% at 2 years. Now, with 39 months of median follow-up, we have a 5-year survival of 71%, which is the best so far we ever had. When the study was designed, we allowed patients to receive a transplant subsequently. With the positive results we obtained, the question of transplant is debatable, and with such a good regimen, we don't see, we maybe need less transplantation. So in summary, high efficacy, less need for transplantation. The importance of this article is setting a new standard of care for this patient today with a Ph-positive disease and improving the cure rate to a level of 70–75%, which has never been achieved before. So what are my commentary on this study? What I think the 3 most important highlights of or findings of the study. We know clearly that TKIs should be part of the standard of care for patients with Ph-positive ALL, should be combined with chemotherapy and given continuously. How much chemotherapy we need, that is unanswered. We know clearly as well that in Ph-positive ALL, we have a high rate of emergence of a mutation called T315I. This mutation of the kinase domain leads to resistance to dasatinib, imatinib, nilotinib, and bosutinib, and it's only suppressed by ponatinib. We know as well that if we want to improve the outcome of this disease, we need to improve the rate of complete molecular remission, and in that sense, ponatinib does improve the rate of CMR from 50% before with dasatinib to 80% today and higher. Therefore, I think the importance of this study resides into 3 things. Number 1, suppression of the emergence of T59 mutation causing resistance to TKIs. Number 2, improvement of the CMR rate. And by improving the CMR rate and eradicating the T59 mutation, we improve overall survival. And subsequently, needing less transplantation down the road. So based on these findings, I think ponatinib should be standard of care for patients with Ph-positive ALL. We're exploring different combinations moving forward with the low-dose chemotherapy or blinatumomab. So the hyper-CVAD or intensive regimen may not be needed, but at least with what we have today, we have a high response rate, great survival, and needing less transplantation. The study, the regimen was a combination of intensive chemotherapy, what we call the hyper-CVAD, given for 8 cycles, 3 weeks or 4 weeks block, and then followed by 2 years of maintenance and then ponatinib infinitely. When the study was originally designed, we did use ponatinib at a labeled dose, which is 45 milligrams per day, given for 2 weeks during induction. And from cycle 2 and beyond, we give it at a dose of 45 milligrams continuously. We don't stop it. For the 8 cycles, during the maintenance phase, we did give vincristine, steroid, and ponatinib continuously for 2 years, and then after that, ponatinib single agent all along. At any time, patient or the donor can go for transplant after discussion with the investigator, the treating physician, as well as the patient. When we enrolled 37 patients, we had 2 vascular events encountered essentially related to the drug. One young man and a woman who had a sudden death from cardiac arrest. That led us to amend the study and modify the regimen. So the study was modified where ponatinib was maintained at 45 milligrams during the first 2 weeks, and then 30 milligrams from cycle 2 and beyond, and with further reduction to 15 milligrams once a CMR is achieved. And after this amendment of the study, we had 80 patients treated. We did not see any serious vascular events encountered anymore. We clearly know that there's a good correlation between the dose given and the rate of adverse events, and lower dose are being effective. That was the design of the study. Of course, patient had a bone marrow up front and every 3 months during the chemotherapy consolidation. And we check PCR every 3 months. Once patient is in CMR, we can follow them by PCR for up to 5 years. The key findings. We published originally on 37 patients. That's what the paper published in Lancet Oncology. And now we update our experience with 76 patients treated and published in Lancet Hematology this year. Morphologic remission is everybody, 100%. CCYR or complete cytogenic remission is 100% as well. CMR, or what we call 4.5 log reduction, we are at 83% of the patient population, and we had 0 early tests. That is what we've shown. With a median follow-up today of 39 months, with a 3-year survival of 76%, and 5-year survival of 71%. Among relapses, we had only 3 patients who relapsed on ponatinib. None of them developed T315I mutation. There was 1 case of E255V mutation known not to be extremely sensitive to ponatinib. Of note, patients received 12 intrathecal chemotherapy, and we did not note any CNS relapse encountered. As I said, patient who had a donor can go for transplantation. We had a 15 patient who had a donor option went to transplantation. So we did the landmark analysis at 4 months at the beginning and then 6 months with a whole set of patients treated. Interestingly enough, a transplant did not seem to improve outcome compared to patients who did not get transplantation. Now, among the 15 patients, few of them had PCR positivity or minimal disease positive for the transplantation, but transplant did not seem to improve outcome of these patients, and that let us think the transplant may not be needed down the road. From a safety profile, we did see a neutropenic fever, not more than what we can obtain with a hyper CVAD or see with a hyper CVAD. We did see hypertension, we did see pancreatitis, highly manageable. As I mentioned, we did see 2 vascular events related to the drug occurring at a high dose of 45 and 30 milligrams, but none at 15, which is quite reassuring. So today we have a long follow-up, and we think ponatinib is becoming standard of care for patients with a PH-positive ALL. So here are my thoughts and as of this study. I think it's a single-arm trial. It's a single institution. Of course, these findings need to be confirmed by other trials, other prospective trials that can validate our point. But nevertheless, this is the best result ever reported. We compared as well our findings to the hyper CVAD dasatinib in what we call propensity score matching, and the hyper CVAD ponatinib was superior in inducing height of CMR and survival benefit by 20%. We've shown as well that having a CMR does predict for the long-term outcome, and essentially identify patient whom transplant is not needed. Therefore, if you get to CMR, you can essentially put transplant on hold. And today we have a new drug called blinatumomab, where it's added to this regimen mainly for patients who have a positive minimal disease, where we can convert to MRD negativity as discussed by Dr. Colbouchet and improve their outcome. So what do we need to do moving forward? We need a confirmation of our findings. A randomized study is ongoing today, comparing low-dose chemotherapy and ponatinib to low-dose chemotherapy and imatinib, primary endpoint being CMR at 3 months and overall survival as secondary endpoint. Second question is being addressed today is, do we still need intensive chemotherapy? If ponatinib is so effective, maybe we can simplify the need for intensive chemotherapy, and that being explored today with either low-dose chemotherapy and ponatinib, or moving fully to a regimen, what we call chemotherapy-free regimen, where we're using blina and ponatinib, and this is being explored as we move forward. One thing I like to highlight is that we still need to do CNS prophylaxis because none of the TKI available today can cross the CNS barrier. And with 12 intrathecal, we are not seeing any more CNS relapses. So in summary, ponatinib is the best TKI for this patient by suppressing the emergence of 359 mutation and improving the CMR rate. A validation of these findings is ongoing. So what are the unanswered questions for the future? Do we still need intensive chemotherapy? The answer is, I don't know. Prospective studies ongoing are in this question. Do we study transplantation? I think we can say with the data we have today that if you have a CMR, transplant may not be needed, should be placed on hold. And third, the new era is to go into what we call chemotherapy-free regimen, and that is being explored prospectively. Thank you very much for your attention.